Good afternoon, ladies and gentlemen, and you are welcome to the third plenary session. It's my honor to introduce, given the time, I'll just get straight to it. It's my honor to introduce Dr. Richard Gakuba, who's the founder and managing director of Health System Innovations Limited. He'll be giving a keynote on the enabling environment for e-healthcare and advancements in the national e-health strategies in the EAC. Yeah, so without much ado, I'll pass the floor on to Dr. Richard. You're welcome, sir.
Thank you, Stephen. And thank you to all those who are following remotely, virtually, and for those who are in Kampala in the conference physically. But first, let me start by telling a quick story about myself. I've spent quite many years in this whole digital health space, but I wanted to take you back a little bit for me to build the context to understand how far we've come from, how far we've come, and how far we are right now. I finished studying a master's degree in e-health in 2005. And shortly after that, I joined the Ministry of Health in Rwanda. But I remember going to do that master's program, and most of the other doctors were like, "Really, what's that you're going to study? Really, what is e-health? What is it even going to help you in future in your whole life?" I'm trying to make you understand here that the notion of understanding the importance of technology in health has grown so quick, but we're coming from so far. Moving on first, in 2006, I was nominated as the National E-Health Coordinator in Rwanda again. And I remember this one moment when my first few months in that job, there was no direction to follow. I was just nominated National E-Health Coordinator, I guess maybe because somehow, having been on a government scholarship, perhaps I had to be placed somewhere. Anyway, that's the joke. But there was no vision, there was no strategy, there was nothing. And I became a bit proactive and put a few people together who are working in ICT mainly, and we developed a national e-health strategy. And this is 2006. I remember one time when one of the government officials who was supposed to be actually helping me to strengthen this strategy and make sure that it becomes a national document. I was like, sometimes we write these documents, we keep them in our wardrobes, in our cupboards, and we never use them. And as in basically discouraging me, just go and act, do the work. You don't need a strategy, you don't need a document. And moving on fast, by the year 2009, or let me go back, 2008, there was a very big conference in Bellagio in Italy, organized by the Rockefeller Foundation, where various topics about e-health were discussed. And amongst those, we're talking about interoperability. So just imagine from 2006, 2 years later, there's a conference talking about interoperability. And there are so many African countries that were attending that conference. It was a new topic because there was nothing to interoperate. There are no electronic systems at all. And in 2009, we had our first approved national e-health strategy. So just 3 years along the road, we had a national strategy that was functional, adopted by the government, and it was already costed. There was already a budget, some money already allocated to it. And I think just shortly after that, I remember Kenya also developed their national e-health strategy. And moving on swiftly, maybe 10 years later, 2016, every East African country had a national e-health strategy. And as you can see, that is really very, very fast advancement from not knowing what digital health or e-health is all about to having national e-health strategies almost across the entire continent. So there has been really very, very important, tremendous advances. And I think that is something we should be proud of. That is something that I think every East African member state should be happy to promote much more. I think by now, most countries have already revised their national health strategies. They have included other things that we never thought of, things like artificial intelligence, things like, using all sorts of technologies, we never knew that we would even use mobile phones way back in 2015 or 16, that mobile technology would be part of our national strategy. So what I wanted to say here in a nutshell is that we've come a long way, but we moved so fast to a point where the strategies are now there. Most countries have costed them. Investments have been made, and there's a lot of work that has been done. So many sectors have been involved. What used to be just an e-health strategy for the Ministry of Health now is a strategy that sometimes, or actually most of the times, involves all the other sectors. Ministry of ICTs are involved, and other government agencies. So I want to say that that is really a very strong advancement. Nevertheless, there have been shortcomings, of course. We've had strategies that were not financed, that sometimes were just developed for the sake of having one, for the sake of showing the donors that we have a strategy, but without necessarily following it. And I think as a takeaway from here, and I think most of you would agree, is that the digital health or national e-health strategies should be respected and financed as much as every other strategies. We always have in the health sector, we have the health sector strategic plan. That we have midterm reviews of that. We have budgets and so on and so forth. But sometimes the e-health strategy is left on the side. It doesn't mirror the rest of the strategic plans at all times. So I think those are things that those are areas that really need improvement. Yeah, so I think we could come back and forth a little bit while talking about the enabling environment, but I thought I needed to tell that story just to show how far we've come and how far we are, and so many things that we have ahead of our times. Moving on quickly again, I would like to move on now to the enabling environment. We know so well that every sector will thrive, be it health or any other, will thrive because there's an enabling environment. Both, and when I say enabling environment here, I'm talking about both public and private environment. So there's obviously a list of things that need to be in place for digital health, and I keep interchanging digital health and e-health. I'm sure you guys understand what I mean, but digital health is a more popular word now than way back when we used the word e-health. So first and foremost, there needs to be a national strategy. There needs to be a strategy by the government. Let me speak up from the topic that we just left off, which is the national strategy. There needs to be a strategy by the government that demonstrates what are the priorities. Do we prioritize, let's say, primary care or community health, or is the priority to implement enterprise systems to streamline services? There has to be a strategy to guide both the donors, the implementers, and the government itself, of course, but also the private sector, because they need to invest in areas which the government has given priority, because that's where the money is. That's where, if they invest in such an area, they are going to reap some rewards. So so having a clear strategy that is very clearly communicated is something that's very key as an enabler of digital health. You all know that most of these strategic documents always stay in our respective ministries. Yeah, some ministries, some governments have them on their websites, but they are not publicized or they are not as public as they should be. There should be marketing of this strategy. Make sure that the whole private sector knows about it. Make sure all the partners know it. Make sure all the donors know the vision and the strategy that the government is intending to follow. So I think that was one key part, that one of the enablers. The second one, also very, very extremely important, is the leadership. I think the reason why, in fact, in the first place, in Rwanda, we had even an e-health strategy way back in 2009, before most other countries, is because the leadership was very, very keen on using technology as a pillar for all development, not just health, but all the other sectors. So leadership is very, very, very key. And we're not talking about just high-level leadership, but also at a technical level. We've had, of course, things have advanced very quick, as you all know. But the way back, we used to have, they are called departments of ICT in every ministry. And these are people who don't necessarily understand the business of health, but they are running, not really digital health as such. Their main concern would be, having networks, computers, and so on and so forth. But now, of course, every country has evolved from that. And we have either departments or units or people who wake up in the morning coming to work thinking about digital health, be it strategists, be it implementers. So having leadership at a ministry, at the ministerial level, is very, very critical, not just the top leadership from presidents and ministers. So, and I think, again, confidently, I can testify that I think in every East African member state, there is some level of technical leadership or a department of e-health or digital health that is functional. And of course, the leadership I'm talking about here is not just for the health sector, but it must be cross-cutting in all the other sectors, because you can't have digital health implemented well without infrastructure, which is not necessarily a mandate of the health sector. So it has to be cross-sectoral kind of leadership, not just Ministry of Health isolated kind of team. Yeah, so that I thought is another very key enabling environment factor. The third one is legislation and policy. It's so difficult for technologies to be implemented without legislation, without policy, without regulation. So there should be, in every country, there should be a regulator. There should be somebody who sets policies in place. Say, for example, you want to implement a telemedicine system. Will the service with the clinical services that will be offered reimbursed by by the insurance? That's such a very critical thing. If a government does not put such policies that a telemedicine service is also regarded as any other service that's provided to a patient, and hence should be reimbursed just like visiting a doctor physically. So I'm just talking about very simple, but there are several other policies and regulations that need to be put in place. Data security and exchange, who is allowed to share which medical records with who, all those kind of policies need to be in place to make it possible, both for public and private digital health investors. So that's the other. And the fourth one is the infrastructure. I know that some time back, it was very, very difficult for us to be able to even think about sharing a file that is, up to a certain size, because there was no internet, or wherever there was internet was very, very, very limited. I remember way back in 2009 when we were implementing health information exchange, and we had singled out this one district as our pilot district, and we had our, all the different registries and shared health records implemented at the central level, and we expected the hospitals and health centers as well to be able to enter medical information in the electronic medical record system, which you had provided to them and trained them, but connectivity was almost impossible at that time. But now. We don't have 4G, we have 3G, we have fiber broadband. So it's a good advancement we've had, but we all know that in the remote places of our countries, it is still a big challenge, especially for countries that are so big that you can't provide all the whole infrastructure. it is very, very paramount that you have infrastructure in place, especially for connectivity. Of course, the private sector, again here, I keep coming to the private sector because all these things really can't be done without the private sector investment. Telecoms and other internet service providers need to be given incentives to build the required infrastructure, even in remote areas, so that the digital health services can reach all the different areas. The other factor, which is very critical to enable digital health investments, is the services and applications. There are so many, and here let me kind of categorize between the private and public sector. There are so many types of software that can be implemented. We have open source and proprietary systems. Of course, that's been a battle in almost every country. What should they adopt? Should they go for open source? Should they go for proprietary systems? But whatever the case, there has to be guidance in the appropriate softwares to be implemented. There has to be support in country to support those kind of softwares, and give guidance even to the private sector. Which kind of technologies would you want to have implemented in the private sector, in the private health facilities, but also helping the private hospitals and clinics in guiding them what are the, as government, what the best choices could be. So anyway, having a choice of softwares and applications that are available and usable and supportable by within the country is another very critical factor. And the other one, coming towards the end, is the human resource that is required. We've had, in the past, we've had doctors and nurses and all the clinicians who are really very good at doing their job. And then you have technologists or computer scientists or programmers who also are very good at doing their job. But there was a gap in that was yet to be bridged, whereby the technologists would understand the healthcare business, and the healthcare providers will have a notion of understanding of what technology is all about that can support them. And thank God we now have those kind of professionals. Talking about how far we've come, I think in 2009 is when we had our first master's program in health informatics here in Rwanda. And that has also helped us to breed a mass of skilled people that can go not just serve here in Rwanda, but also be able to serve as digital health experts elsewhere. But again, this is not just about Rwanda. Of course, I know in most of these East African countries, in Kenya, there are quite several programs. So that's a very good thing, and should be always promoted. And make sure that all the universities have this kind of programs to support the digital health services, both from a planning point of view and also implementation. And last but not least, because we don't have time to exhaust everything, but I can't stop without talking about standards and interoperability. There has to be standards that are set for a country that should be followed by everybody. And this is obviously especially for the ability to share information. We've had instances where you have private hospitals, for example, implementing health information systems, and they are only to be told that no, they don't qualify, they don't fulfill certain standards, they can't share their information, and so on and so forth. I don't want to go too technical here, but those of you who are digital health experts understand we need to have certain standards set in place. There are those that the government must definitely put in place, such as identifiers, for example. If you're going to identify a patient, regardless of where they are, there has to be a certain identity, and that ID is most of the times, or if not all the times, should be provided by the government. So, okay, here is your electronic electronic ID that can be identified by not just for other services, which is always the case, but also for health reasons. And that's just one identifier. There should be identifiers for health facilities and so on and so forth. And medical standards like ICD-10 or ICD, whichever number that the country chooses, which is standards coding for diagnosis, and so many others, as well as technology and medical messaging kind of standards like HL7 and so on and so forth. So without those kind of standards, it becomes really difficult for innovation, for both the private sector and the health sector to be innovative, because they don't have guidance. They don't know what they should be using as standards. But once those standards are adopted and officially communicated to everybody, that becomes really, really very, very helpful. So I think I don't want to spend so much time. I don't know how many more minutes I had, or I've already gone past. But I would like to stop here and say thank you so much. Try to touch both on the on how far we've come and how far we've gone into developing and having national e-health strategic plans, and also the different factors that affect a very beautiful enabling environment, which everybody aspires to have. Thank you so much, and I hand back to you, Stephen.
Okay, thank you, Dr. Richard. I think that has been a very insightful discussion. I like the fact that Dr. Richard previously worked in government and is now in private sector, so he's able to do the bridge between government thinking and private sector implementation. Because of time, I won't go over what he has said, but I believe when it comes to the discussion, we shall be able to unpack some of the key insights that he shared. Up next, I'll invite Mrs. Gracia and Andrea Midana. I hope that's the correct pronunciation. She's going to be making a presentation on the impact of COVID-19 related policy measures on maternal health care in Madagascar. I hand the floor to you, Mrs. Gracia. You're welcome.
Thank you so much. Yes, so I'm Gracia. I'm a master's student in Berlin, in Germany. But yeah, we work with partnerships in Madagascar, but I will just introduce you in a second. So first, let me share my screen. Yes, okay. All right, here we go. So I want to talk about our study called The Impact of COVID-19 Related Policy Measures on Maternal Health Care in Madagascar. And like I said, I'm a master's bioinformatics student in Berlin, and I've been working in the data science team of the Global Digital Health Lab at the University Hospital here in Berlin. So first, let me introduce the partnership, as I just mentioned. So we are working partly in maternal health care, and this partnership actually evolves about a mobile maternal health wallet. So this wallet makes it able for pregnant women or pregnant individuals to receive digital or to fulfill digital payments or receive savings in this mobile money wallet. Where the savings, just mentioned, the savings mean that when they deliver in one of the facilities of our partnerships, they only have to pay 50% of the fees, whereas when they actually come in for ANC drugs or prenatal ultrasounds, they get electronic vouchers, so these are actually for free. And the mobile maternal health wallet is actually performed or implemented on a platform which is called M2Madi. And this is a multi-payer platform that connects beneficiaries to the different types of health financing over simple mobile phones. So what the beneficiaries, so the pregnant women, do is they enroll in public or private health programs, and via a mobile phone or maybe even just a SIM card, they send, they save, or they spend mobile money for the health expenses, or they get health information. Then this information is sent to, for example, the healthcare providers, so the hospitals, which are able to identify the beneficiaries, to submit claims or receive payments, as well as securely transmit medical data. And then there's, of course, also the insurance providers. So they're the ones that manage the beneficiaries, the claims, and the payments, that monitor the real-time data and also look out for fraud protection, as well as distribute behavioral nudges. So we, as the lab, work with this M2Mati platform provided or financed by the Maternal Healthcare Partnership. And in our lab, we actually do different studies. And now I want to explain what exactly we did, or actually how we got to do this study of looking at the COVID-19 related measures on our data. So what we recognized last year was when there was a lockdown, for example, in Madagascar due to the pandemic. So it started around the 23rd of March. We realized that also in our data, for example, for the deliveries, that the numbers would go down. And even though that the lockdown was in total, I will just talk about it later in more detail, but just as a background information, even though that the lockdown was several months long, we saw that there were obviously different ups and downs, but it differed from what we would usually see in the months or years before that. So this is when we thought, okay, we noticed these changes. We have a suspicion that the COVID-19 measures have an impact on these. So we wanted to look more into what really happened and what happened in our data especially. So just a very short run through the most important things that happened in our study period. First, in February, 10th of February 2020, there were the first suspension of flights to and from China issued by the Malagasy government. And then on the 20th of March, there were the first COVID-19 cases detected in Madagascar. So that was when the government declared it a public health emergency and suspended all international flights. And shortly after, as you can see here, on the 23rd of March, they issued a lockdown, which eventually was always prolonged, or a few of the measures would be taken down and then implemented again. So it was a little up and down, but overall, officially, the lockdown lasted these many months. And our study eventually looked at the payments, the saving transactions, and the electronic vouchers, so for the ANC drugs or the ultrasounds. And we wanted to analyze how many of the 3,460 patients in this time frame from 29 basic health facilities were impacted by these measures. So in total, our study period was from the 1st of January 2020, so that we would also have a few of the data before any measures happened, of course, until the 27th of August 2020. And the statistical methods that we used was mostly a regression discontinuity, which I will talk about in a second, like what that is and how exactly we implemented that, and also a sensitivity analysis for the bandwidth, so some of the parameters around the lockdown. Don't worry, I will explain all of this just in a second. But the overall results that we got were that we could see an impact of the measures on all three data sets, so on the payments, on the saving transactions, and as well on the vouchers. And we also assume that due to these results that we were able to observe, there could be long-term consequences due to the lockdown. According to the Oxford Stringency Index, I just wanted to explain very shortly how strict eventually the lockdown was. So just to explain shortly, so as the ones that came up with this index, they say that the containment and closure policies record the information on containment and closure policies such as school closures and restrictions in movements. And in fact, in Madagascar, the lockdown did include something like curfews, or that schools were closed, or that markets were only open, for example, in the morning, things like that. And from all of the days that we included in our study period, so in the beginning you can see, okay, this is our sort of like pre-lockdown data. The stringency index is 0, so as in there was no lockdown, or there was no measure. And we defined it in a way that when the measure was over 17, this is what we consider like a stricter method. So this is where we would say the lockdown began, and we can see that all of these different measures, would that be, for example, that schools were closed and so on and so forth, are all in this higher value of the stringency index. Now, before I talk about the results, as I promised, I will talk about the regression discontinuity method very shortly to make sure that we all understand what we're looking at later on. So the regression discontinuity is a quasi-experiment which aims to calculate the unbiased estimate of the local causal treatment effect on outcome variables. And it is actually described as a method that is almost as good as a randomized experiment in measuring a treatment effect. It is especially useful for programs which use a cutoff point, which we do, for example, since we defined our cutoff point as a lockdown, or when the lockdown starts, rather. And this cutoff point helps us to assign the treatment or program eligibility. So yes, as I said, everything before this cutoff we will define as pre-lockdown, everything after this cutoff as past or after the lockdown. And this method is especially helpful or usable when experiments are not feasible, or when we want to evaluate programs under real-life conditions. And there are two types of this method, the fuzzy and the sharp method. In our case, we actually look at the sharp or deterministic one, because we are, yes, very stringent on the fact that the day the first lockdown happened, so the 23rd of March 2020, including that day and everything after that day, is what we will define as during the lockdown. All right. Oh, and sorry, one last thing. It can mostly be applied in medicine, epidemiology, or public health. So now that we know what this method can be used for, let's look at our results. So one of the things that we observed was that there was a significant decrease of payments before and after lockdown, which we can actually number as about 63% decrease. And if we look at this slope, for example, what we could see is that the daily increase was usually around 1.35%. So that's how much we would see on a day-to-day basis. But during the lockdown, this increase reduced to about 0.48%. We also see similar things in the savings. So in the savings, the decrease is a bit lower. It's about 47.4% for the number of saving transactions during the lockdown. However, we also see that the daily increase, which was 0.34% before lockdown, changed to 1.41% per day. So even though overall the number of saving transactions decreased, on a daily basis, it was a bit higher. And this could be explained, or we could assume that even though overall pregnant individuals saved less, we could assume that the amount may be changed. When it comes to the electronic vouchers, so the vouchers for ANC drugs or ultrasounds, we see another drop. This drop is numbered as around 43.9%. And the daily increase in this case was about 0.39% per day, However, this trend didn't actually change so much during the lockdown. And as I mentioned before, when it comes to RD analysis, something that we have to think about is, yes, even though we are deterministic, we have a strict cutoff variable, we still have to think about how much data before and how much data after lockdown do we actually want to include. And this is why we also had to do a sensitivity analysis before just looking at these different values of decrease or increase, which we obviously did. And this included using the Imbens-Kalyanaraman algorithm to choose an optimal bandwidth, so to choose an optimal amount of days before and after the cutoff. And we did this for different bandwidths, which were ranging between plus or minus 20 days from the optimal bandwidth that the IK algorithm returned to us. So, for example, for the payments, we actually looked at 57 days before and after lockdown. And if we played around with this, like I said, about 20 days before and after, we could see that this decrease of 62.7% that I just talked about was in fact robust. We see a similar thing with the savings, so we would look at it about 83 days before and after lockdown, and this decrease of almost 44% was seen regardless of whether it was actually 63 or 103 days after. However, for the vouchers, we saw that, yes, for the optimal bandwidth of 90 days, it would be around 47% less vouchers. But if we change this number a little bit, so 70 days or 110 days after, then we can see even numbers going up to 57% of, 57% decrease. And here's also just to show you how that would look like in a plot. But all of this is what we see in summary in this table. So what does all of this tell us eventually? On the one hand, we know that the COVID lockdown had a severe impact on the savings and health-seeking behavior of pregnant individuals. The vouchers, as well as the payments and the savings, were similarly reduced. Well, actually, the payments were reduced the most from all of them, but we could see this behavior in all of these three data sets. And in our study, the pregnant individuals were mostly unemployed or worked in an informal sector. So they are the ones that are more vulnerable to economic effects of a lockdown. Which leads us to the second conclusion, which is that the economic impact of COVID-19 will most likely increase in the next months, if not years. So there should be more efforts for financial risk protection, as well as universal healthcare coverage, which should be prioritized because it could, for example, prevent that women go less to the doctors or have to save less because they need this kind of money for, well, other priorities such as buying food and so on and so forth. And another thing that we could conclude from our study is that the digital tools can in fact deliver real-time data, which helps in times of crisis. Because it can play an important role in health system strengthening and also realizing how the behavior of the individuals have changed during such a thing as a pandemic. So that was everything I wanted to talk about today, and I'm really eager to answer any questions later in the discussion. Thank you.
All right. Thank you, Mrs. Gracia. I think that was quite insightful, and we look forward to unpacking it in the discussion. I'll go ahead just to invite the second presenter, Mr. Peter Kibe, and he'll be presenting on mobile health consulting as an option for improved access to healthcare in Nairobi slums. Yeah, so you're welcome, Peter.
Thank you very much. I hope you can see my screen.
Yes, we can.
Yeah. My name is Peter Kibe. and I'll be presenting on mobile health consultation as an option for improved healthcare access in slums of Nairobi. On introduction, we know about mobile phones, communication, technology that has been in use in various sectors, be it finance, agriculture, education, and in health as well. So within the mobile phone technology, there has been a lot of pilot studies, and particularly in health, where we've had various interventions being developed. But as we had in the morning, most of the interventions have remained at pilot stage, meaning that there has been less of a sustainable continuity of those interventions. So in this study, we intended to explore the environment for use and implementation of mobile phone consultation as an option for healthcare. We operationalized the mobile phone consulting as when someone with a health need uses communication technology to consult a healthcare provider, and this could be a whole range of healthcare providers as defined by the context. So it could be a nurse, a medical doctor, a clinical officer, or a pharmaceutical technologist, so long as that person is providing healthcare services. Our objective was to explore the perceptions on provision and use of consulting in that context. So our design was explorative, and we did this in two informal settings in Korogocho and Rwandani, which are slums within Nairobi. And the choice of this site was informed by the fact that we, at Africa Population and Health Research Center, have been conducting an urban demographic health surveillance within these two sites for the last more than 20 years. So it was an ample site for us to test this. So our implementation was informed by a study that we were already conducting. And from that study survey, we had a question on who has used mobile phone for seeking care previously. And so in this exploration, we targeted those participants. And as you can see here, we got these participants here, and then we recruited them to participate in focus group discussion. And then this participant also, we also formed an advisory group. We were a combination of members of the community and research and key persons in mobile health technology who were reviewing different stages of how these questions were formulated. And then we did a cyber mapping and desk review and highlighted key digital health services and policies that are in place within Nairobi, within Kenya. And then from these results, we went on to have focus group discussion and in-depth interviews with healthcare decision makers, healthcare providers, health service providers, and users of healthcare services within the slum. So these are some of the interviews that we did. So we did structured interviews for the policy experts. And then we did also semi-structured interviews with digital consulting service providers. There are several, so we target to reach 5 per site, that is 10. And then we did key informant interviews with clinician healthcare providers at different facilities. And then because healthcare users were quite many, so we decided to do a short form of in-depth interview, which we call mini interviews in this context. And we recruited community health volunteers, traditional healers, drug vendors, and members of the community who had responded to using mobile health phone for seeking care. Then we had 2 focus group discussions in every site, where we discussed how these, we allowed them to discuss their perceptions on how this care was. So some of the finding, I present this shortly because more results will be expounded in a later publication. But in the findings, the key theme were on access of mobile phones. We found that people in the community had mobile phones, and they're cheap and easy to afford. For example, these respondents say they're all over, they're easily accessible. And this was a participant from one of the sites. And then another one said mobile phones are available anytime you want to use, because even if you don't have, you can get one from the neighbor. So this points to the point of accessibility versus ownership. We were not looking at ownership, we were looking at accessibility. And then the type of phones that we also wanted to understand, the type of phones that people use, to understand the scope and the environment with which they seek care. So people have smartphones, and one said that smartphones are nowadays Chinese made them available. They are very cheap, even with 2,000 Kenya shillings, which is like $20. You can get one. And then it depends on what kind of phone, depending on one's income. So one could have a phone that is moderated by the kind of income they have. And then people also had those button phones that are owned by men. And people thought that women owned this smartphone mostly because of leisure and getting involved in social media platforms. So the ownership of phones, they said more women own phones than men. And those who own phones are one participant said those who own phones mostly are women, because even if you look at the demography of the area, it is women who are many. So that is ownership by numbers. And then the youth below that 5 years old also own phones, and this own mostly the smartphones. So we asked about the networks and airtime and how they are able to use. And people have, one person could have more than 2-3 SIM cards. And this was mainly because the different type of 3 main network providers in Kenya had different packages that they were interested in. For example, if you want to send money, then there's one provider that you go for. If you want to buy cheaper internet, there's one provider you have to go to, and it's the same for making calls. So on the services themselves, I'm trying to avoid mentioning the service care provider, because we asked them if they would want their services to be made public. Some did not agree. So this primary healthcare provider app said this is the community saying, if they have anything in their hospital and is being offered there at their place, maybe a reduced price or free, they will tell you. And this was a service provider that is based in the slum, and they provided a range of services of which some of them they didn't want, because of the legal issue, didn't want to point them out there. And then there's another one that is openly known. It's called Wangukanja Foundation, which deals with gender-based violence. And they keep, what they do to go about it. And then we had also services for maternal and consulting services. For example, Service X. This X is referred to a service provider. It offers information to pregnant women, and it's from Jacaranda Foundation. But the reason why I've skipped the name is because we have not fully de-identified the information. And then Service Y.
Apologies about that. I'll just give Peter maybe a minute to
go back to school. So how services are. Sorry?
I think I lost you. Could you just go back to the slide? Yeah, I think yeah, if I just pick it from there.
Yeah. So So the X, Y, and Z are service providers within the slum, and these are respondents from some of the users of those services, and just highlights what kind of services they offer. And then, so on a range of services, on how people use services within the slums, digital forms. One is they do call healthcare providers, and this is where there's such a framework that has been established by healthcare service or facility. They use text message, they use apps, they use chatbot, especially for consultation and health education. So the most common, we asked about the most common sought after healthcare and which one was convenient to use in the app. And many people felt that chronic diseases, because they enhance continuity of care, you don't necessarily need to travel to the health facility to get these services. And this is HIV, example, TB, and diabetes and hypertension. And then they also thought that diseases with high stigma, and examples are STIs and mental health, were their appropriate diseases to be provided through these platforms. So the main challenges that they encountered while seeking care, one was network failure, electricity to charge their phone, cost of calling, and lastly, miscommunication. Miscommunication is where you might be saying something else, and the person on the other end misunderstands you, and you may end up getting a wrong diagnosis or wrong referral. So we also looked at the benefits of M-consulting, and we had issue of access of services during disruptions. For example, if there are industrial strike of healthcare providers, natural disasters. And to give an example is during industrial strike, most facilities go slow and they don't provide certain services. But if there's an established line of linking up with the health facility, then you're able to follow up and know what course of action to take. And then there's confidentiality, and this can be viewed from both sides. So the benefit in this case, as mentioned by this participant, is if you have gonorrhea, if you're telling him or her, because, and this is a doctor, because maybe somebody you respect, so you know illness is illness, and it's a person's secret. So this is someone who resides in the slum, and the health facility is within the slum. And because they know the healthcare provider, they find it difficult to go and convey their messages of more benefit is on saving the time and enhancing transparency. Transparency mainly because sometimes when you go to health facilities, there are extortions that happen around from the point of entry. You might not know who is dealing with you, who is providing services to you, because some facilities are big and they don't have like a regulated attire that people wear, especially these small outpatient facilities. So people get extorted while trying to seek care. But when you're dealing with the healthcare service, digital service provider, then you know on the other end there's a verified provider. So on our recommendation, we recommend future consulting to be an option for chronic care diseases, that is non-communicable diseases, infectious diseases, and other medical issues, especially those that require a high level of privacy and have a high likelihood of stigma. And then we also recommend future partnership and networks. And this we recommend together with point 3, which is ensuring there is a core design when developing an M-consulting or digital platform, so that you have the users and the providers interlink in a way that they're able to understand each other and easy to take up the service. And then finally, we need capacity readiness for healthcare personnel, because most of them, their background and training as of now may not have adequate skill in terms of what kind of digital skill they have to deliver healthcare services. Basically, that's my presentation. I'll share this, and we can read more in the paper that we will be publishing soon. Thank you.
All right, thank you very much, Peter, for that. So up next, we have Celestine Twizere. He'll be presenting on digitalizing the hospital patient trajectory and secondary use of electronic health records, EHRs in Rwanda. You're welcome, Celestine.
Thank you, moderator. Good afternoon, everyone. I'm Celestin Twizere. I'm the director of the Regional Center of Excellence in Biomedical Engineering at the eHealth. And I'm presenting in order to share the experience in this ongoing project around the digitalizing the hospital patient trajectory and secondary use of electronic health record in Rwanda. And this is from this Rwanda National eHealth Strategy, where the point 11 on the National Registry Shared Health Records, terminology services, and the interoperability layers, where in order to implement this Rwanda National eHealth Strategy, we are working on this digitalizing the patient trajectory. So the goals and the objectives, the first is to improve the continuity of care in Rwanda by building the digital patient trajectory, the patient referral, and harmonize various electronic medical record systems used in Rwanda by adding a common data model layer, and then to work on just-in-time data access reuse for public health purposes, as guiding preventive policies or epidemic alerts or real-time health indicators generation and clinical research purposes. So, what is the today problem? As like those sockets, each one is coming with each health care facility is using his own electronic health record. Then there is no interoperability with other systems, and integration and data sharing is complex. Then the today wrong solution is that each one is bringing his own adapter on his system, and sometimes this become complicated. So on the side, what this project is coming to solve, and what is the continuing on the existing problem. On the side of the patient, when is transferred, first the transfer is a paper-based. The patient is moving with a transfer on a paper, and there is no record of a previous clinical consultation, and then there is no appropriate medication due to lack of past information. And toward the smart solution and leveraging on the OMOP common data model, we want to map the patient migration form on the existing electronic health record in Rwanda. Why are we digitizing the patient migration form? First of all, this will help to know the patient history trajectory from health center to referral hospital through the district hospital. Then as the healthcare are interconnected with referral and district hospital, then the transfer, the transferring mode will be if necessary, because they are interconnected. and there will be the proper medication and then proper healthcare service delivery. As this is a pilot project, we have the participating healthcare facilities where we have one referral hospital, 3 district hospitals, and 2 health centers. And each one is using his own electronic medical record, where mainly here we have the open clinic, open MRS, and one on the healthcare at Remera, the eWatch Hub medical system. This is a home-based solution, and from the 6 healthcare facilities, we want to use innovative methods in order to link all the 6 facilities, leveraging on the OMOP technology, the OMOP common data model, where we want to extract, transform, and load. And this is what we call the mapping. We want to map those electronic medical record to the OMOP. Then the outcome of this project is a clinical data oriented, where we are sharing the patient data, and less process oriented in terms of number of physicians available, number of beds, and also some process aspect can be covered, like the count transfer. We are the project stage. We are now at the technology development and implementation, where we have conducted already the need assessment for at the level of hospital and the health centers, for hospital director, data manager, and IT. And we have done the semi-qualitative interview, questionnaire based, and for MOH and the RBS officials. So here, what I can say is that there is no medication, procedure, or other interventional act on a human subject, no patient identification data disclosed, all data and the IDs are encrypted, and no one can identify the patient, except only the treating physician. The project design, as you can see on this figure, the idea is to have more patients to be treated at community level, and at community level, at health centers level, it's there we have many patients. Then between the health center and the district hospital, we'll be having this patient migration form, and the patient migration form will be mapped on the electronic health record and the OMOP using this patient migration form. And at the end, we'll be having a less number of patients at the referral hospital. And those, as I said, those healthcare are linked, and there is kind of transfer and counter transfer when it is necessary. Main research activities. First, we have the training activities and the need assessment study at each hospital. The data manager extracts needed patient information to be mapped to a common database and shared throughout the system. And the patient information are defined by the physician and are on patient migration form. The data manager and the IT, assisted by project expert, map the element to the common data model. And once this is done at each hospital, the system is interconnected between hospitals, so each hospital can read other data based on the unique patient ID. Then at the end, we'll be testing the architecture and the system. The team role and the responsibilities. We have the Minister of Health Rwanda, the DG Clinical Services to align with MOH roadmap, the RBC to align and synergizing with ongoing work, the University of Rwanda, this is CEBE, the University of Ghent in Belgium, and 6 participating sites where we have the DG hospitals and the health center responsible, IT responsible, and the data manager. Then the Minister of ICT Research to align with other project roadmap and frameworks, and enable to synergize with other supported work and project. Where we are now, we have already conducted the need assessment and identified all needed tools in terms of equipment, network, and personnel. For the personnel, we are working with IT and data managers at all levels, means the 6 healthcare facilities. For equipment, servers, desktop, and laptop available, plus network 4G coverage and optic fiber network. The electronic health record, we have Open Clinic, Open MRS, Iwacho Hub medical system, and the system architecture to link the 6 participating sites. And then we are at the level of mapping the patient migration form to the electronic health record and OMOP. So thank you for your attention, and ready to respond to questions. Thank you. Over to you, moderator.
Thank you, Dr. Celestine. Our last presentation before the discussion will be from Yusuf. Yusuf, you're very welcome.
All right, good evening there. Good morning on the U.S. side. I'm here in Washington, D.C. My name is Yusuf Enriquez, founder and CEO of Indigenous AI. We're building a large digital health platform that we've partnered with partners there in Kenya to build out what we think is the future of precision medicine. Topic today is really looking at blockchain and healthcare, but also I think some of the presenters before me kind of touched on a little bit of the area on where we see the digital transformation of healthcare in Africa, and I'm super excited to be engaged in some of the efforts. So a little poll question I'd like to start off with. What percentage of clinical drug trial research participant are European white males? If you wanted to put it in the chat, I don't know if we have that function, but you guys could send the response on A, B, C, or D, or the percent number. Background, I'm a serial entrepreneur. However, before that, I spent over 2 decades in the military. I'm originally from Kingston, Jamaica. My dad named me Yusuf Nkrumah Enriquez after Kwame Nkrumah. I spent 6 years in the military as a special force medic. I've had deep experience in drug approvals, medical device approvals, and then in my last part of my career working for the government, genomics and clinical trials. Last September, I did a MIT Hacking Racism and Healthcare Challenge. You guys could Google that and get an idea of where Indigenous came from. And it's really out of the lack of clinical diversity in clinical trials. And we could touch a little bit on that. Previous work, my first company, I lost veterans to suicide, and so really started looking in genomics in the Department of Defense and the VA. Veteran Affairs wanted to start looking at how high levels of stress, cortisol in your body affects your genes. And so in 2013, I was overseeing a lot of PTSD research, working for the NIH, FDA, and the DOD, where we worked with Mount Sinai, NYU, and Columbia. So my first startup used a patent out of Mount Sinai that looked at genes that are directly correlates and are affected by cortisol in your fight or flight system, And so I was able to take that patent and go out to Silicon Valley and built a blood test for PTSD. Also looked at anxiety, depression, bipolar, and currently that's being evaluated by the Department of Veteran Affairs to look at high-risk patients and high-risk veterans and soldiers to see if we could reduce the high level of suicides. How this correlates with Africa, I know there's a huge stigma around mental health, and so this could be an opportunity to provide more objective, more private assessment and private diagnosis where, this would be more between the patient and his provider using a digital health platform. As I mentioned, MIT Hacking Racism in healthcare with MIT stemmed out 21 different solutions, and these were solutions all from social injustice, lack of clinical trials, maternal health, women reproductive health, and as you see here, the one that I head up was startups and spinning out tech solutions. Out of this, our nonprofit, which is called Black Tech Matters, we were able to accelerate some of the companies which just graduated a couple of months ago. So if anybody who got it right, again, 95% of the drug trials right now globally are European white males. And so you can see the implications of why the increase of minorities and diversity, both women and Africans in the diaspora, needs to be considered. Also believe that, Africa is the future of precision medicine, given its uniqueness and most genetically diverse population in the world, especially East Africa. And so that's the explanation of why Indigenous planted its seed there in Kenya and is working with other partners there in order to build out a healthcare ecosystem that we think will drive precision health equity and provide, the baseline to start looking into drug discovery and developing medications that have deep representation of Africans and women in trials. So indigenous AI is really what we call the next generation of sequencing. And if you've heard about the viral pathogen sequencing that's going on with Africa CDC, we saw this as an opportunity to be engaged. And, we plan on developing this biorepository of African genome repository in order to drive drug discovery and help push leapfrog Africa into the 21st century of being a leader in drug discovery and drug manufacturing in order to be able to provide for the 1.2 billion individuals on the continent. We believe it's time that Africa start looking at, engaging in drug discovery and also manufacturing so that in case another pandemic occurs, we're not waiting for other countries to develop vaccines, which currently right now, I checked the news, only 1% of the Africa continent has received any form of the vaccine. So we're building a repository that will help that Afro-Latin, Afro-Caribbean diaspora with omics data in order to do early detection, early prevention, drug discovery, and clinical disease management of some of the diseases that plague the continent. And as you see here, one of the uniqueness of the technology is that we're combining clinical data from hospitals and genomic data, which is sequencing. But we understand that point of care and digital health data platform is needed, given that mobile technology is advanced on the continent, and we see that as a way to provide, patients with electronic health medical record on their mobile phones in case they migrate throughout the continent. They have that readily available, and we've partnered with our partner there, E.A Record, there in Kenya. And so we've been diligently acquiring over 140,000 patients on that platform that has partnered with one of the large Telecom, which is one of the large telecommunication company there. And we've been driving this model. So again, wanted to touch base on where we see innovation, interoperability, and also genomic sequencing all coming together and creating that ecosystem of having patient engagement through mobile technology, where we could have that exchange. And so this has been identified as one of the sustainable development goals. In our business model. And so, one of the great things about this is, although Africa has been traditionally behind on innovative technology, the timing couldn't be more perfect given the fact that a lot of the data repository that are across the globe, including the US and the UK, have struggled with this for years. And a lot of the data core elements that has been collected are in multiple different systems. And so we see this as a great opportunity to use digital health along with mobile technology in order to engage patient, do patient recruitment, and then eventually, develop a robust electronic healthcare record that has genomic data and clinical data in order to make better disease management and treatment outcomes for patients on the continent. So, one of the other areas that, we wanted to make sure, given the high sensitivity and privacy around patient data in general, not just clinical data, but we do understand that genomics and privacy and how to get to future of better treatment and disease management will rely on some level of blockchain capability along with AI machine learning, just because of the sheer fact that genomics data is so large that it's going to require AI machine learning in order to interpret and do early detection, early prevention. Just to give you an example for the IT folks on the phone, one sequence, whole genome sequencing of an individual's entire human genome is a little under a terabyte of data. And so, as you can imagine, as we start to grow our repository to 100,000 and 1 million, we'll need high levels of AI machine learning partnership, which we've gathered with a field record and also Encryption, who is our blockchain partner. And so we feel like, given these control parameters, blockchain has the ability and the capability to help leapfrog healthcare into the 21st century as far as looking at user control, enabled security, having the ability to gather data using a federated model where that data and that patient's individual genomic data sample does not leave the particular repository that it's in, which is ongoing right now with multiple countries that are working on how to incorporate that federated analytics architecture so that each country could govern, data privacy and residency of the samples, but still provide the de-identified data in order to come up with, aggregated data set that's going to be required. Data standardization is another unique component of the blockchain that would enable and provide security there and some uniformity. And I think the major one for us being indigenous that, we're looking at the ability to tokenize and compensate individuals that provide their samples for research. And so the blockchain model we've developed, because we have that mobile digital health platform, will provide us with the opportunity to compensate individuals that provide their samples on a continuous basis, which is, a little bit different from what clinical research models are right now, where it's a one and done on the front end, and they collect the data in the sample, and then your samples is being used for drug discovery without any patient compensation. So we believe we've built a model that is a strong ROI and provides not only best interests of patients, better treatment, disease outcome, but also providing some level of compensation given the high level of need for more diversity in clinical trials.
Thank you very much, Yusuf, for that. We appreciate that. And now we open up the discussion to the floor. And I'd just like to just as a wait for either any questions to be posted in the group. I'll possibly not just ask and please feel free to talk to it. We're talking about e-health and as a new norm and as something that we should now take up aggressively. But with e-health comes the concern about data privacy and protection. So I know that in Uganda and Kenya, we've got laws that have been enacted around data privacy and protection. So I want to just ask the panelists just to talk about the readiness of the health sector in complying to data privacy and protection, because you're aware that the law would, if adhered to, would spur use, would grow trust in e-health. So what are your thoughts on that? And I'll go with probably the keynote speaker first, Dr. Richard, and then Mrs. Gracia, and Yusuf, and maybe Celestine. Thank you.
Thank you so much, moderator. That's a really very interesting question. Privacy and security for medical records is a big issue now. I recall in 2017, I was doing a fellowship in the US, and one of the head of the hospital, the big hospital in Massachusetts, told me that before, bank information used to be worth around $2 per record. For those who hack it and sell it. But he also told me that medical information was actually becoming way more expensive for those who can, again, obtain it illegally and sell it. It was going for about $30 per record because of how important a medical record is. So it's extremely important to make sure that we abide by the security of the information because it's extremely important. It can be either career ending or it can be even life ending if your medical information is out there. So how ready is the health sector, the Ministry of Health? I don't think it's really the mandate of the Ministry of Health to be ready, but rather those who develop the systems, the technology developers, those who build electronic medical record systems, those who deal with security, because a Ministry of Health will never have a security expert in protecting a medical record. But where maybe you host it in the National Data Center or wherever the medical record is kept, they should be equipped with the most advanced technology to make sure that the protection of that medical record is guaranteed. So in other words, I would think what the Ministry of Health should do is probably to make sure that those standards, security and confidentiality standards are abided by for all those that are dealing with medical records, but not necessarily in their hands to implement it. That's my take on that question. Okay, thank you, Stephen.
All right. Thank you, Dr. Richard. Mrs. Gracia, over to you. Do you have any thoughts, or Kibe or Celestine?
Yeah. Hello, can you hear me?
Steven, I didn't get you when you said the campaign that's
yes.
Yeah. What I can add on what Dr. Richard said. Yeah, it's not the mandate of the Ministry of Health, but there is a need of synergy in the collaboration when during the development of those innovative system or electronic health record, because each one is responsible in terms of privacy and security. And this is why the national data centers through the Ministry of ICT and others are supposed to come in, and especially the regulators. Regulators are supposed to come in and working with researchers in academia platform in order to have this kind of synergy to be sure that the product is secure and there is this privacy. Thank you.
I would like to just shortly add from our perspective, or rather from the M2Madi platform that we work with. I mean, I also work very closely with the developers of this mobile health wallet. And I know that, for example, because we are here in Germany, we're in Europe, so we have the GDPR by the EU that is like, yeah, above us, or that's the legal guideline that we have to follow. That even for me, that I'm in the data science team, I'm not able to see all the data of these pregnant individuals. So I can see, for example, that they claim, for example, that they went to the doctor and got an ANC drug or an ultrasound, but I don't see their name, I don't see the phone number that connects them. There is just, some pseudonymic indicator for that we use, or the IDs even for the different treatments. So I can just see, okay, this kind of treatment was issued, but I don't know of whom it is, and so on and so forth. So even within our working frame, we're really trying to make sure that we take this privacy and data protection very seriously, and also like our developing team is always on to, when it comes to fraud detection or data protection, that we make sure that we really, that we really follow these guidelines, not only because of the law that's above us, but even within ourselves. Like, I don't need to know the phone numbers of these women. I just need to know, okay, who filed this claim, so that for a study, I know, okay, this many women have filed something in the last 2 months. So, yeah, that's just from our perspective. But of course, I agree with everything that was said before. And I just wanted to add that real short.
Thank you, Mrs. Gracia. I don't know, Peter, did you have anything? If not, we can just do you?
No, thank you, Stephen. First of all, I agree with fellow panelists. The main thing that I would just want to add is that we normally know that some data is money, and everybody's interested in that. And as researchers, as innovators, as scientists, our main role is to make sure that the data that we have, that we are able to we access, translates into evidence that can actually improve the lives of people. And in doing that, we are guided by international laws. And where such laws don't exist, for example, in some cases of countries, especially in low-income countries, then we have to uphold the laws that exist and the international laws that are known. And mostly in research, that is very clearly explained. But what we need to do in our local government is to ensure that we keep pushing to have these laws enacted, whether by parliament, whether by any form that is required. But basically, we need to work with the laws that exist, and we also need to be guided by the ethics, knowing that our output is what informs the evidence that is acted by the government. Thank you.
All right. So maybe before we talk about the last mile, maybe I'll just there's a question here. Is there any available application to capture emerging disease and monitor in progress? What about electronic database to monitor MDR in East Africa? Open access? This is a question that has been asked from the audience. Who would like to take that?
I don't know of one which is open access at the moment, but I do know that, for example, even in our lab, we are currently working actually specifically on ETV, so tuberculosis data, meaning that we want to expand our platform not only for maternal health care, but also for this disease and the healthcare, of course, in regards to this disease. So we do want to monitor, for example, how many people come in to do a sputum test or come in for the first, second, third check-in, if they have been healed or cured from the disease, and so on and so forth. So that is something that Ntumadi is planning to do in Madagascar, in the south of Madagascar. As in for whole of East Africa, I'm not aware at least of something like that, but I could imagine that there is an approach or is a strategy to include this amongst the region, not just very particularly in the south of Madagascar.
Yusuf, thanks for joining again. There's actually a question for you. What are the low-hanging fruits or quick wins for AI use in EAC, especially resource-constrained settings in which digital technologies are highly needed to address health and social welfare challenges?
Yeah,
That's for you.
Thanks. Can you guys hear me?
Yes.
Yeah. Got booted off. I don't know what happened. I think, where we see and why it's been interesting to me is, we've seen a lot of movement in the mental health area. I think that's an area that with, AI, machine learning, we could destigmatize. I think it's similar to, I know the African continent has a lot of stigma around mental health, and that's as close comparison as we had with veterans that were struggling with mental health here. I think one of the quick wins with using AI is we're working with Afia Record, who set up an AI Center of Excellence in Kenya. And so a lot of the work that John Kamara is doing there in, helping, not only just build AI solutions, but also train the workforce economic development of individuals on the continent will be super important. So we have the resource and the talent on the continent in order to build out some of these technology that could be used to engage patients, especially in rural areas, as Peter mentioned. I hate to say the slums, but really trying to identify some of the pain points and identifying where we could have the most reach with patients. It's going to come down to shifting that point of care from the hospitals to the actual, bringing some of this technology to that patient. So that's why you see the infrastructure has to be very solid, having that technology infrastructure along with the privacy and encrypted data so that information can be collected in some of the rural areas where you won't have hospitals, and being able to take that information back in order to make disease management decision for patients that don't have the capability or the wherewithal to get to a stood up hospital. The other area, I think, as I said, looking at how important it is to start looking at how the continent could be more engaged is using AI to look at early detection, early prevention. I think, if we're able to start identifying some of these ailments and disease a lot earlier, then we can start, treating some of these disease. So, I think those are some of the areas I think AI is going to be. And then as we stand up more AI Center of Excellence, I know that's an initiative that John has.
Okay, so there's that's question which I think which is on the last mile delivery, and we'll just speak, invite the different panelists to just share their thoughts.
I like to compare this last mile delivery to a system where something has to happen within a system. And I refer to the complex adaptive system where things are very interconnected, but for you to have an end result, then this interconnectedness have to be aligned. And as rightly mentioned, infrastructure is a key thing. But within the region, we also have disconnection in terms of legal aspects. The priorities in each country within the region are different. We have a private sector that operates slightly different from how government does things. And when we talk of private, we're talking about insurance. How do they come in? How do they fit in the entire framework at the end? So for me, I think, from where I sit, I think for us to really address this last mile delivery, we need to start thinking together as a region rather than building silos where each country is building its own framework. So when we start thinking, because when we start thinking as a region, then it means that what is happening, for example, in Kenya is what is also being developed in Rwanda, is what is being developed in Burundi. And that means that once the system is beginning to take shape, then it means we'll be speaking the same language, and that's when we'll be closer to having this last mile delivery being realized as a dream. Otherwise, as we are now, each country has different priorities. There are different things that people are responding to. But I believe there is an opportunity, and this pandemic, this COVID, in as much as it has really caused havoc, has given us a new challenge to see how things can be worked on and improved. And this can be used as a learning lesson towards the future of last mile delivery. Thank you.
Thank you, Peter, for that. Okay, a bit of a comment. If Grace is not saying anything, Gracia, we'll just go to. Are you saying anything?
No, thank you. I don't have anything to add. I think especially what Peter just said is, yeah, that's exactly my thoughts.
Okay. And to the panel, thank you as well for having the time today. To the audience, you've been awesome. Let's go into a break, and we'll come back for the second part of this panel discussion, and we'll continue to discuss e-health and how it can be enabled. Thank you, and yeah, see you guys in a bit.